A very good evening to everyone. Thank you to Aradhana ma'am and Sushma ma'am for joining us for today. Uh, we have Vivekan presenting an orthopedics JC to us. Uh, Go ahead, Vivekan. Just start.
Okay. A very good evening to one and all present here. I'm Vivekan, a second year medical student, and today I'm going to present a paper on effect of hypothyroidism on complications in patients undergoing total knee arthroplasty in Indian population. So, starting with the title, uh, some key aspects of the title which should be mentioned always in an ideal journal are the study objective over here, hypothyroidism on the complications in patients undergoing total knee arthroplasty. This has been clearly mentioned, which is a good thing. And
Sorry, Vivekan, we can't see your slides, I think. Is anyone able to see?
Ma'am, I think we can see, ma'am.
Oh, is it? Okay.
Yeah, yeah, visible, ma'am.
Okay.
Yes, ma'am.
okay, okay. The study population over here is Indian population, which has been mentioned as well. But the study design has not been mentioned over here. So this leads us to an ambiguity in our mind, so this study can either be a cohort study or a case control study or a randomized control trial. It would have been better if they had mentioned this in the title itself. I will be following the strobe checklist for case control study for further slides. This paper was taken from Indian Journal of Orthopedics, which is a very reputable and peer-reviewed journal, and it has been publishing since 1967. It has an impact factor of 1.08. The authors of this paper are V. Ratnakar, Savan Kumar Pawar, Ashutosh Dwivedi, A.B. Suhas Masilamani, Kishore Karumari, A.V. Guruva Reddy. They are all from Sunshine Hospitals from Secunderabad, Telangana. All the authors have some papers published in reputable PubMed index journals. Moving on with the abstract of this study, a lot of patients have been undergoing total knee arthroplasty these days, and a significant proportion of them have hypothyroid disorder as well. As a result, it becomes really very important to know if hypothyroidism has any role to play with respect to total knee arthroplasty. This study is a case control study with 600 participants who underwent total knee arthroplasty. TKA is nothing but total knee arthroplasty, and this abbreviation is being used extensively in my PPT. The results show that the medical and surgical complications were more in hypothyroid patients. However, they were not statistically significant. Conclusion of this study was that the rate of hospital stay, surgical site infections, and complications were higher in hypothyroid group when compared to control group. However, they were not statistically significant again. Now, according to the strobe checklist, the study design has been clearly mentioned over here as case control study, and the results were mentioned with all the odds ratio and the p-values. However, certain ambiguous things will be covered in my next few slides. The main objective of the study was to identify if hypothyroidism is a risk factor for post-total knee arthroplasty complications. Total knee arthroplasty is an orthopedic surgery performed in case of severe arthritis, mainly in elderly population. It is a cost-effective solution which provides improvement functionally and provides pain relief to all the patients. Thyroid hormones are required for the growth and development of musculoskeletal system. Hypothyroidism was shown in some studies to be an independent risk factor in periprosthetic joint infection. However, with respect to the complications following post-knee replacement, there is very less literature available. The scientific rationale was explained well in the introduction, and the aim and hypothesis was clearly mentioned as well. The aim of the study was to evaluate if hypothyroidism plays any role in complications following total knee arthroplasty, and the hypothesis was in case of hypothyroid patients, the the number of complications arising post surgery is more than non hypothyroid patients. Talking a little bit about the surgery, in case of now, in case of a normal healthy individual, the knee joint is normal over here as seen in the first picture, wherein the cartilage and the bones are intact. Whereas in case of patients with osteoarthritis, cartilage begins to break down and bone spurs are seen where the bones seem to meet. And hence surgeries are performed wherein implants are put in place. The A typical total knee arthroplasty consists of two main components. The first one being the femoral component and the second one being the tibial component. The bones are cut and shaped, following which the implants are placed. The femoral component is placed at the lower end of the femur and the tibial component is placed at the upper end of the tibia. And the tibial components consists of a metal plate and a plastic spacer. Moving on to the methodology, the study was a well-designed case-control study, and Institutional Ethics Committee permission was obtained. Consent form has not been taken in this study, and the authors have mentioned this. It was stated that consent form is not required for this type of study as it is retrospective in nature. Generally, what happens in corporate-based hospitals is that at the time of admission itself, uh, the patient sign a form wherein it states that the details of the surgery or the details of the participation in the surgery can be used, and the patient has already signed in that consent. Hence it is not a major issue, and the details of the participants should be hidden in these types of study. It would have been better if the authors have mentioned it clearly. The sample size of this study was 600. There was no exact mention of the location or the study setting in the paper. However, from the information provided by authors in the introduction, it can be understood that the study was conducted in Telangana. The period of recruitment was 2017 to 2019 with a minimum follow-up of 2 years. The data was collected mainly from the hospital records. However, further information on how the data was collected regarding how the segregation happened, how each patient was allotted to each category, and how the controls were allotted to a specific case were not mentioned in the paper. Before moving on further, let us take a basic look at the definitions. So, with regard to a case control study, a case refers to all those patients who basically have a disease, and control refers to all those patients who do not have the disease. Uh, ha- um, However, according to the standard definitions given, for a patient to be put under the case group, there should be two specifications, which are diagnostic criteria and eligibility criteria. Diagnostic criteria refers to those criteria which are essential to diagnose that the patient has that particular disease, whereas eligibility criteria includes all those details such as demographic details like age, sex, which are important in a research. The controls must be free from the disease which is being studied, and matching is the process through which controls are selected such that all the parameters are exactly the same in the case group and in the control group except for the main parameter which is being studied. So in this paper, hypothyroid was the disease which was being studied, and post-knee arthroplasty complications was the outcome of the paper. Now moving on with the inclusion and exclusion criteria, the inclusion criteria included primary type 4 Kellgren and Lawrence grading or osteoarthritis. This is an eligibility criteria, whereas TSH greater than 5.60 milli international unit per ml or previously diagnosed cases of hypothyroidism is a diagnostic criteria. Talking a little bit about the Kellgren and Lawrence osteoarthritis, we can see four major grading in which the first grade indicates that osteoarthritis is doubtful, and second grade indicates that it is mild osteoarthritis, third grade indicates that it was moderate, and fourth grade indicates it was severe form of arthritis. In this study, only type 4 participants were included. Patients with inflammatory arthritis, hypothyroidism, and diabetes were excluded from this study. According to the stroke checklist, the source of case assignment was clearly mentioned in the paper. However, the methods of how the case was allotted to each group was not mentioned in the paper. Regarding control selection and matching, the paper mentions that 600 participants were there, with 300 in the case group and 300 in the control group. However, the criteria which was used for matching was stated only as age, sex, and BMI, that is body mass index. Other criteria such as comorbidities like cardiovascular diseases were not clearly mentioned, which may play a major role in our results. The rationale was explained in the paper. Moving on to the data collection, I have grouped the data which was collected in this research into four main categories. The first one being pre-op, wherein the age, sex, BMI of the patient was collected along with laboratory investigations such as hemoglobin and serum sodium. Post-operatively, blood transfusion required, serum sodium, and length of hospital stay was recorded. And for hypothyroid, which is nothing but the case group, the duration of hypothyroidism and the dose of thyroid medication the patient already was on was measured, along with the preoperative TSH levels. Complications such as delayed wound healing, superficial surgical site infection, periprosthetic joint infection, deep vein thrombosis, and pulmonary embolism were measured. A total of 7,312 patients were screened, and out of them, 600 patients met the study criteria. 300 of them were put under hypothyroid group, and 300 patients were put under the control group. Again, the only difference between the case and the control group being the case group had hypothyroid patients and the control group had non-hypothyroid patients. All other criteria are supposed to be the same. There was no further explanation given on how the study size was arrived at. When we calculated how much the actual sample size should be using the formula, I found out that the sample size per group should have been 513 and the total sample size should have been 1026. The sample size of the study done was much lower than the calculated sample size. Talking a little bit about the surgical technique, how the surgery was done. First, preoperative was done, following which cefuroxime, which is an antibiotic, was injected 30 minutes before skin incision, and tranexamic acid was injected 30 minutes before the skin injection, which is an anticoagulant. Spinal anesthesia was given in cases of unilateral total knee arthroplasty, whereas combined spinal and epidural anesthesia was given in cases of bilateral total knee arthroplasty. Standard midline incision and medial parapatellar arthrotomy was performed, and regional blocks was given for post-operative pain management. Enoxaparin 40 international units was given subcutaneously to prevent deep vein thrombosis, and apixaban, which is an anticoagulant, was given post-operatively for 12 to 14 days. And follow-up was done mainly at two times, which was 30 days after the surgery and 90 days after the surgery. The statistics done in the paper was mainly using the two tests, which are chi-square test and Fisher exact test. The qualitative and the quantitative variables were measured using percentages, and quantitative variables was also measured in terms of mean and standard deviation. Risk was defined as an odds ratio and 95% confidence interval of a complication. All analyses were two-tailed and the significance level was set at 0.05. Moving on with the results part of our study, the first major thing is the demographics, wherein the authors have stated age, gender, and body mass index along with serum albumin. Age, gender, and body mass index were the criteria which were matched for the cases and the controls. Over here, there is not much of a significance. The p values over here are much greater than 0.05, which indicates that they were not very significant, except for this one thing, that is, females were more in the control group as well as in the hypothyroid group, which is mentioned as less than 0.01. The authors have not mentioned if chi-square test was used or if Fisher exact test was used or if some other tests were used. It is always better if the authors have mentioned the type of test used for each particular table they are mentioning. The number of participants are assumed to be 300 in each group throughout the experiment. There was no mention of any missing data, which would have certainly been there in almost all the researches. So missing data should have also been mentioned in the journal. Moving on with the complications, which was the main scope of the study. The complications are studied under two main headings, which are the medical complications and surgical complications. Medical complications included pulmonary embolism, deep vein thrombosis, transfusion of medicine, transfusion of blood, and mild and moderate hyponatremia, whereas surgical complications included surgical site infection, wound dehiscence, delayed wound healing, prosthetic joint infection, and periprosthetic infections. All these have been given as the p-value is much greater than 0.05 and the odds ratio over here is less than 1, which indicates that, though odds ratio being less than 1 indicates that the complications are higher in the hypothyroid group when compared to the control group. However, p-value being greater than 0.05 indicates that it is not statistically significant. Thus, finally, we can conclude from this table that the hypothyroid group had more complications, but it was not statistically significant. Also, one more important thing to note is that the confidence interval, which has been mentioned over here in brackets, includes 1 in them. In all the ranges, 1 is being included, which means that uh, the odds ratio of 1 indicates that it does not matter. That is, the control and the hypothyroid group has the same number of complications and there is no difference between them. Moving on to the next parameter, which was the postoperative length of stay in hospital. The p-value over here has been mentioned as 0.0921, which is greater than 0.05, which means it is not statistically significant. This is a graph which shows that the hypothyroid group, the complication seen in the hypothyroid group, which is shown in red color, is much more than the complication seen in the control group, which is indicated by the blue color. Uh, Another subgroup analysis was mentioned in the paper in which the case group, that is the hypothyroid patients, were divided into two further groups, wherein the first group, which is being mentioned over here as euthyroid group, these patients were previously diagnosed with hypothyroidism and they were under treatment. So the thyroid hormone levels were almost corrected in this group of patients, whereas in the other group, that is hypothyroid with high TSH, that is thyroid stimulating hormone, uh, the patient's the patient's hypothyroidism was not under control. So on analyzing all the complications which I mentioned previously, there was again no statistically significant increase or decrease in the number of complications. Again, chi-square test or Fisher exact test was not mentioned over here. Moving on with the discussion, hypothyroidism was found to be in 18% patients undergoing total knee replacement. According to the study results, hypothyroidism is not a risk factor for post-operative complications in patients undergoing total knee arthroplasty, and there was no significant increase in infections in hypothyroid patients. The study is consistent with some of the previously reported results. However, it does contraindicate with other studies. We will be looking at some of the previously done studies. The study conducted by Weinberg et al. In Mayo Clinic found that there was no obvious significant increased risk of post-surgical complications in hypothyroid patients. This is in line with this research. Another study conducted by Bozic et al. Found out that hypothyroidism was not an independent risk factor for prosthetic joint infection in total hip and knee replacement. The first two studies are in line with this research. However, the next study, which was done by Tan et al., showed that thyroid hormone played an role in increased risk of prosthetic joint infection. And the study by Grunfeld et al. Showed that the patients receiving thyroxine for hypothyroidism had developed wound dehiscence and infection in foot and ankle surgeries. The last two studies over here indicate that this study contraindicated with the studies which showed that thyroid hormone plays a role in uh, complications. Moving on with the limitations of the study, there was selection bias and underreporting of comorbid and adverse events which are possible in a retrospective study. All case control studies are generally retrospective in nature. As a result, selection bias is something which cannot be avoided. The sample size used in the study was small. 600 patients was small. A much larger cohort will obviously give us much better results. The cause of hypothyroidism was not mentioned in the study. The cause of hypothyroidism could have either been something like Hashimoto's thyroiditis or simple things like deficiency, iodine deficiency, or even hypothyroidism following some other previously done surgeries. According to the checklist, bias has been mentioned in the paper. However, external validity, that is whether this study can be applied elsewhere to other set of population, is not mentioned in the study. The conclusion from this study was hypothyroidism is not a significant risk factor in causing post-total knee arthroplasty complications. This was the final interpretation from the study. The authors have mentioned that the study did not receive any grants from other organizations. Now, a question to the audience. Would this article influence your clinical knowledge and practice? Thank you.
Thank you so much, Vivek. Would any audience members have anything to say or to please do participate. It's an open event. And yeah, I think the thyroid functions and the correlation with the entire total knee arthroplasty, it's actually a very interesting topic. Two things that you really wouldn't think are related.
Yes, Manali.
Sushma ma'am, Aradhana ma'am, anything?
Okay, see, one thing which I have found in the article was we don't know the antibiotic protocol which they have followed. How many days of antibiotics was given, what antibiotic was given. Different surgeons have different protocols, and we really don't know how many surgeons operated. Was a single surgeon operating, which is impossible for 600 patients. I feel
Yes.
there were multiple surgeons, each have different surgical skills, each have different outcome. So I think that has to be considered when they are publishing any article. That becomes an important thing. Maybe because it was a retrospective, they would not have considered it, but it matters a lot during the outcome. Okay.
Yes.
Yeah, and not even a single hospital. I think there were multiple hospitals with multiple surgeons involved in the study, correct?
Actually, they have
Yeah,
not mentioned about that in the paper, ma'am. So that is actually,
exactly. That has to be mentioned because single surgeon operating, it matters a lot rather than multiple people operating. They have different outcomes. We can't compare them, in fact.
yes, ma'am.
Yeah,
Like they should have
yeah,
mentioned if the same surgical team operated and
yes,
the hospital in
exactly.
was performed.
Yeah, exactly. It outcome is different in each under each person. Okay, well presented. It was a good presentation. Okay, yeah. From orthopedic point of view, I would like to add few things. Hypothyroidism, definitely, we have to think of so many conditions or so many things when we are operating as orthopedicians. Okay, one is osteoporosis. We are thinking of, usually it is associated with osteoporosis. And as the last article which you in the discussion part you mentioned, the skin healing problem, which is
Yes.
present in these cases. So both together can alter the outcome. Okay, and how well controlled they are also is not mentioned in the article. Uh, During follow-up, how well controlled they were during the follow-up when they were assessing the outcome. We don't know. If they are well controlled, fair enough. The results might be good, but still, osteoporosis associated with hypothyroid gives not that great results because implant loosening chances are very high in hypothyroid cases. Yeah, that's from my point of view. I think Shushma ma'am should help us to scrutinize the article more.
Hi, thanks, Aradhana. Thanks. I was still driving, so I just let you
Oh,
all finish it. Okay, now I've
you're
stopped.
done, ma'am. Yeah, okay.
Yeah, I'm done. I'm done. So I just kept totally quiet, listening in the car. Thank you so much, Aradhana. That was very nice. And that is, I think Vivekan almost all mentioned everything, starting from
Yeah,
title to abstract to everything. The only problem here is, as you both actually, Arandama mentioned, as this type of studies are very well done in other countries where there is a great medical registries. Here they have tried to do a case control study from India, but I think we don't have registries, proper registry of the patients. So this type of studies are called as nested case controls, meaning you have a registry that is if all the patients, if we do it in Victoria, all the patients who are coming to Victoria are in and around Bangalore, and we take everything starting from their diabetes to hypertension to when they took the medicine, everything will be in my registry. There, it is a big cohort of patients who are attending Victoria Hospital. So, in that, I identify one thing, that is total knee arthroplasty, and then I select the case and go back and select my control from the same big cohort. So, I'm going to insert one case control study inside a large cohort study. That is called a nested case control study. Okay, so this should have been done in that way. It should have been a nested case control study where you insert one case control study into a large cohort study. At that time, you sort of get all the details of the cohort. There, you very well you can select your case and as well as match your control. But here they have tried to do something like that only, but they have matched. Case is also not defined properly. So if you go to any JM and read what is a case, they will tell 100 different criteria to select one case. Here we are saying it is TKA and some complication. We have neither defined the complication. Now we have not defined the complication for a case, and no other criteria. Except their matched control matching is done on age, gender, and BMI. But for every comorbidity, there will be a matching. And there is something called as propensity score matching, where they match the case so well with the control that we will know that the hypothyroidism only has caused that complication, nothing else. Like that, you have to match the control. So that can be done by, I think the softwares do it. In case if I have one diabetes patient here, the control will also have like one diabetes patient only. Here I have diabetic hypertensive, the control will also have a diabetic hypertensive. So like that, very close matching happens between case and control. Otherwise, we cannot assess whether hypothyroidism was really a risk factor or something else caused it. As Aradhana just now mentioned, that osteoarthritis and what is the stage of that osteoporosis, nothing we know. And then whether the patient had controlled diabetes or uncontrolled diabetes, we don't know, because of which medical complications would have happened. So we absolutely have, because of this matching problem, I think we may have a little bit of a doubt in saying that because of hypothyroidism all this happened. That is one problem here. I hope I was clear.
Yes, ma'am.
Okay, so the matching is the problem with case control study, and here we have not seen any attempt by the authors to really do a proper matching, because of which we cannot say whether hypothyroidism was really a risk factor. Okay, and one more is coming to statistics. Yes, they have done odds ratio, but we do something called as logistic regression. So logistic regression only you get it adjusts, there is some sort of blinding. Now if we want to see whether age is a factor, then it blinds other factors and gives us an odds ratio. So normally in many case control studies, you all have to read about this regression and all that. So they do logistic regression and get the odds ratio. It is a little better statistical tool to assess that whether this risk factor is an association to cause the effect. Okay, so that is one. And if you go back to result slide, no, Vivekan, you mentioned confidence interval, but let's go to the first table. If you can just share that again.
Yes, ma'am.
First one is the basic demographics, right? So why do we do this basic demographic comparison?
Ma'am, so that we get to know if there is any significant difference from with respect to controls and hypothyroid group with respect to say age, gender, and all.
Okay, so this is the only table where we do not want any significant results. You don't want the p to be less than 0.05 because you want to say that both the groups are similar. They are not different. So if you get significant p value, then you are going to say that they are different and not comparable. That is not what we want. Actually, the only table where you do not want any significant results. So say that both the groups are similar for my comparison.
Okay.
Okay, so that's the significance. And then the authors definitely have to mention the statistical test which was used below the table. Okay, so we'll go to table 2.
Yes.
Okay, so this is where the highlight of the day comes from. So here, if you just see as Vivekan said, odds ratio, usually what we say is odds ratio of 1 is no effect. Okay, so odds ratio of less than 1 is protective and more than 1 is not protective. So when you see an odds ratio of 0.49, first odds ratio you see 0.49, in the brackets the confidence interval is 0.04 to 5.52. That shows that the confidence interval is so wide, and it also includes 1. So 1 is the no difference line. Okay, so if your confidence interval includes 1 number 1, okay, 0.0445 it is. So you can imagine how wide it is, and it also includes 1. So when it includes 1, we will say it has no effect. That is what we are trying to tell you. And nowadays the result interest on the p value is coming down, and they want to rely more on confidence interval. So from next JC onwards, I think we will tell them what is p-value, what is confidence interval, everything. So that everybody looks into what is a confidence interval and what is a p-value. Okay, so now the p-value what we are seeing here is 0.68. So in plain English, what is it? In English, you want to say what is the p-value? Everybody knows p-value less than 0.05 is significant. No? Okay, so instead of saying less than more than p-value in your article, you have to always mention like this what they have mentioned. What is the exact p-value? So now a p-value of 0.68 means what?
It means that the pulmonary embolism, which is the complication over here, it is not whether it is more in control or whether it is more in hypothyroidism. That is not statistically significant.
In English, you were asked to explain what is p-value of 0.68 means. Okay, you are going to say like that when the null, considering that the null, I think all know what is null hypothesis. So considering that the null hypothesis is true, there is 68% chance that we will get the observed result as this or as extreme analysis. So when it is crossing 5%, we are going to accept the null hypothesis. That means there is no difference between two groups. When it crosses 5%, I am going to say that I'm going to accept the null hypothesis. Okay, anything more than 5%.
Could you explain the 68% concept once?
Let's 68, let me leave that and then go back to 0.005, which everybody knows. So when we say p-value is less than 0.05 significant, so let us understand what is this. P-value 0.04 first. Okay, 0.04, there is 4% chance that when the first sentence in the null hypothesis is true, there is 4% of 4% chance of getting this observed result. It is in a very simple way again. So that means you are going to reject your null hypothesis. You guys have really to understand this. When you think more than now the p-value is 0.10 or something like that. Then when there is a 10% null hypothesis is true, there is 10% chance that the observed result can be caught. So anything above 5 you are going to accept the null hypothesis, saying that both the groups are same, there is no difference. So p-value tells you very minimal information. That is why when the American Society of Statisticians, they have asked all the journals to consider confidence interval, not the p-value, not only p-value, because it is a dichotomous here. P-value either you say significant or not significant. You never know the range. Okay, next time onward, let us keep saying what p-value by saying it more times in English. I think we may understand a little bit more.
Yes.
Okay, I think it is difficult for you right now. Whatever I told you about p-value or confidence interval. But I think little more you start reading, you will understand. But this all ratio, I want all of you see again 0.1, there is 0.29 and 1.29. Whenever it includes 1.2, whatever is your value, I don't worry. We are not interested in this. It is not ratio, you have to give the and here the next one ratio is 1 and you can say 0.00616. Confidence interval cannot be this wide. Okay, so many times it would be because of the sample size also. So confidence interval always should be as narrow as possible and should not include one. If it includes one, it is not a significant ratio for us to conclude anything. So from this you have to understand that. Okay.
Yes.
I think I confused you more than explaining, but a little bit of reading is required. Prior reading is quite understand what is actually a link. Okay. If you have understood, but I'll send you what is p-value and what is not p-value. It is a wonderful article which all of us do read. What is p-value and what is not p-value. Okay, I'll send that article into the group. Okay, and then next table was the same like that we have discussed. Okay, and then in discussion also the authors never made an attempt to justify the study. Actually, in the introduction, the justification they gave was such kind of study was not done in India, but they would have always said that there is a lot of controversy regarding whether hypothyroidism is a factor or not. And then I think from India, the literature as the author says very minimal. So they haven't read this, which is very good. But in discussion, we don't know why they could have explained why they chose those complications in particular and how your thyroid hormone influences those complications. So that this is totally missing. It is comparison with the study and say this study said this is a risk factor, that other study is not a risk factor, and we do not know why this controversy exists. Okay, so that attempt has not been made by the author, and the strength and limitations as they have said that sample size is small. Instead of all the authors we see in Indian articles, they keep saying the sample size is small. When you determine what is the sample size, they cannot say that sample size is small for me to comment on anything. But here, totally the sample calculation is missing. Which is very wrong, unless I know what is my sample size required to identify whether the hypothyroidism is a factor or not. That itself is not minimal. The results are very unreliable because studies like that by not determining sample size become very unreliable results if we don't have sample size calculation prior to doing my study. So there are all online calculators which is very accurate. You just have to determine what the odds ratio expected from previous study and you put in and revise these results. So it is really good to do the sample size prior to starting the study, not ultimately saying that my sample size small is my limitation. In a sample, if you are not checked the right sample size, then all of your odds ratio value, everything becomes very unreliable. We cannot say that it was right because the study will not have that power to determine how was my result. So the power of the study drops down in my sample size. So there's one. And then the discussion and conclusion actually was given by Vivekan, but the author said that what was the author's conclusion?
Yes,
Your conclusion.
The rate
What was the author say?
The rate of surgical side infections and complications were higher in hypothyroid group and when compared to control. Those statistics did not significant.
Okay. So we set out to say whether hypothyroidism was a risk factor for complications. But here you cannot say that it is not, though its numbers were higher statistically or not significant or not. You just have to say because all the odds ratios are not significant. Hypothyroidism was not a risk factor. Got to for TKA complication. That was the conclusion. Always your objective and conclusion should be in line. Okay, should be the same. You cannot change your conclusion based on what results you get like this. Okay, so your conclusion should be you set out to say whether hypothyroidism is a risk factor for some complications, TKA complication, or ultimately hypothyroidism was not found to be a risk factor.
Yes,
That is my conclusion. Ultimately, the question which nobody answered, whether this would really change your clinical knowledge or practice or anything. So we just wanted to say that because the selection of case control was not like that, sample size was not given, so we do not know whether the results are reliable. Hence we are doubtful in adopting this into our clinical knowledge. Maybe further very strongly designed studies are required. And one more thing, Vivek, what I wanted to add was, for this objective, whether the study design is, if you want to identify something as a risk factor, is case control study a proper design?
No, ma'am, actually, a cohort study would have been better.
Okay, so see, either a cohort or a case control study can be done, but we have a lot of advantage in cohort because it is prospective study. In case control, as we know, there will be a lot of missing things in the bias and not. But the main advantage of case control study is it can be done very fast and costless. Cohort study goes on for years and years and it costs a lot for the principal investigator. So that way, case control study will give us faster results, but more reliable would be a cohort study. Okay. And I had a question for Aradhana actually, whether the thyroid and everything before we take the patient to surgery, they would see that it is controlled, and usually everybody will be very well controlled before they attempt such a big surgery.
Yes, ma'am. In any pre-anesthetic evaluation, that needs to be controlled because from anesthesia point of view and orthopedic point of view, for us it may not be that problematic. But if a patient is hypothyroid, for anesthesia drugs and for them it becomes a high risk group.
Yes.
Yeah, for us we are bothered mainly regarding the infection or any other complication arising out of systemic effect of a hypothyroid patient. But for surgery may not be that much bad as compared to anesthesia complications.
Yes. And then Denazepam was given for 15 days, so that would really take away all the patients who were at high risk for TB or hypothyroidism. And that's why we have 1 month patient who got primary hypothyroidism.
Yeah. That protocol is nicely mentioned, but the other things are not mentioned at all, which are important.
Yes.
Yeah.
Especially antibiotics and how long they stay in the hospital and everything like that.
Yes.
Yeah, maybe it was just an attempt to do case control. Maybe a part of our medical records will also not contain all the information. So that
Yes,
is
ma'am. We lag in documenting the findings. Yes, ma'am.
it is not software based or anything like that. Very prompts you fill this column, fill this row, things like that. So in other countries it is much easier compared to India where we don't have proper registers.
Yes, ma'am. And they have the same protocol for all patients, ma'am, in other countries. Here, protocol keeps changing. Yes, ma'am.
That is true. The hospital protocols are the same. Hence, I think they have other countries not mentioned everything here. As you said, inside the hospital itself, the practice changes a lot.
Yes, ma'am. Yes, ma'am.
Okay, I think that's from my side.
How is this kind of like study which, as you said, the case is not properly defined, sample size is not properly given? How is this accepted into the Indian journal of orthopedics, which is pretty quite prestigious?
Yeah, very precious. But other things are properly written. I mean, it is not very bad to be rejected, but we can always sort of improve from time to time. We are in another sort of infancy stage of publishing and going ahead now. I think we will get better soon.
Also, one reason why I feel they included this study was this was the first study about hypothyroidism. It's in the country. Yes.
So even in science and many Indian research, I found a very small mistake because here sample size of getting 300 itself when there is no registry is a good number. Though it was not size determined and all what we saw what are negative points, but getting even 600 patients is a big sample size, and then that would be the reason. Otherwise, it is you know well written only. Yes, for sure. It was very well done and the slides were very nice.
Thank
Yeah,
you.
sorry.
So you now doing pretty well like in literature and how should we interpret odds ratio and confidence interval?
I sent an article in the Science Club on how to interpret the odds ratio by the Chitranjan and from and he was the one who taught us what was the basics of statistics in St. John's. So I really like that article which I found on Science Club. How to interpret the odds ratio and look at this gadget for all of you to read that. And I'll forward the p-value, what is p-value and what non-p-value. So I just want all of you to read that. Then I think a lot of concepts will get clear. And as you rightly said, interpretation of odds ratio will be very, very important. Okay, that I have sent that article really will understand in plain English. That is in plain English what is the meaning of odds ratio. So that is basically where we have to take relative risk and where we have to take concentration. Okay. So we read that, I think we will discuss again. Okay, Malini, is that all?
Yes, ma'am, I think we're done. Thank you so much, everyone.
Thank you, Suchara.
Yeah, thank you. Thank you.
Should we
Yeah.
really thank Bharat for taking
I learned so many things today. That I want to do offline in your department also. Ma'am,